Welcome to today's podcast. My name is Pearlie Brewer, and I will be your host. Today's podcast guest is Nadine Wentzell. Today we're going to talk to Nadine about substance abuse in the workplace. Welcome, Nadine.
Hi.
Before we actually get into more of a discussion with Nadine, and we're going to ask her in a moment to talk about her background, we're going to do something a little different on today's podcast. Today's podcast focus is on the current state of substance abuse. So Nadine's going to give us more background information on really the sort of the status or what's going on out in the workplaces today relative to substance abuse. Then in 2 weeks' time, we're going to have a part two. And part two is going to focus on substance abuse, but it's going to focus on fit for duty. What workplaces need to be aware of and have in place to ensure that their employees are fit for duty. So what we're going to ask you to do is listen to today's podcast. And if you have any questions relative to something you've heard on today's podcast relative to substance abuse or something you'd just like to know that maybe we didn't ask, jot that down and send it off to us at podcast@ssnb.ca. That's podcast@ssnb.ca. And I'll repeat that at the end of the podcast today. As well, if you have any specific questions you'd like for Nadine to answer on our second podcast relative to fit for duty, these are very complex topics. It's not an easy solution to determine if someone's fit for duty. There's a lot of complexities to it relative to the workplace. There's a lot of legal implications as well. So if you have some questions you'd like for us to put to Nadine, again, send them off to us in the next week or so, and we'll be back in about 2-3 weeks' time with Nadine and for the second part of our podcast, and she will answer any questions that you send in. So to get going today, let's start by getting Nadine to tell us about her background in the topic of substance abuse.
Thanks, Pearlie, and thanks for the invitation to do this. You know, when Bill approached me last week, I was very easy to say yes, and it's a topic that's near and dear to my heart. It's something that's been part of me for a very long time. I'm a pharmacist by education, and ironically, when I first was thinking about studying pharmacy, one of the reasons was because I'd had some experience with substance use in my own family and some tragedies around that. And then, you know, as you go through school, through university, that kind of went by the wayside and other things take priority. So I did work as a pharmacist for community pharmacy for about 6 months and got completely bored. And then I worked at the Children's for about 3 years in a tertiary care center, the IWK Children's Hospital here, and did some really cool things. But then went on to do a number of other things that I always needed my pharmacy degree for. And one of the most interesting and what really started me, or I guess brought me back on course to this area that I'm in now, was working with Health Canada as a narcotic inspector. I worked for them for 10 years. I did work primarily in Nova Scotia, Newfoundland, but across the country. And I was responsible for the application of the federal regulations as they pertain to pharmacists, physicians, any health professional, veterinarians, wildlife biologists as well, who had federal access legally to narcotics and controlled substances. So I saw a lot. I learned a lot. I also taught at the Canadian Police College at that time, and I worked with plainclothes and undercover police officers, and that was very interesting and sometimes a trial by fire, and I learned a lot in a very different context from them. So, and then I, of course, did work with other police forces across the country because the police loved to work with me. I didn't need a warrant, so anytime they had a concern, then I could do a document review and determine whether or not it was worth their while to investigate further, and I was involved in some pretty extensive investigations as well. So I learned a lot through all of that. And then I ended up teaching at Dell for a while, but what kept coming back to me was this whole area of education around substance use. And so I started my own business about 20 years ago, and it's what I've been doing ever since. So I work with employers to help them manage substance use in the workplace, to make it safe and healthy. And that's the focus that I use when I approach the work that I do. It's a medical model because I'm a pharmacist by education, as I've already said, but I don't look at substance use as a a character flaw or a moral failing. It is a medical disorder, and it's been on the books, the DSM now 5, the Diagnostic and Statistical Manual for Mental Disorders, for oh my goodness, I don't know, at least 50, 75 years probably. So it's been recognized professionally by psychiatrists and psychologists for a long time. And now finally, I think more and more people are becoming more accepting of the idea that it really is a medical condition. There's still a lot of work to be done. There's a lot of stigma. And a lot of it's unconscious, bias. We default to thinking, we've got bad people that we just need to get out of our workplaces. And that doesn't work from a whole bunch of perspectives, primarily from the perspective of human rights, because under the Canadian Charter of Human Rights and Freedoms, and employees are protected who have disabilities are protected, and substance use disorder is protected grounds under the Federal Charter of Rights. So employers have a duty to accommodate. What that means, and we'll talk more about this as you alluded to with the fitness for duty component. We'll talk more about that during that time, but it means that employers have to, in whatever capacity they are able to, accommodate the individual to help them be healthy and safe. Now, I'm not saying you accommodate someone so they work when they're under use of a substance and not safe, but you help work with the person to help them address what they need to so that they come back to the workplace, that they are safe and healthy and able to be productive employees. So that's a bit of background. I have clients in Canada and the States. I belong to a number of organizations, drug and alcohol testing and industry associations. One thing I'm most excited about is within the last year, I've been a part of an organization that's newly created. It's the International Association of Medical Review Officers. And I happen to have the good fortune to be the chair of that organization. And what it is it's an organization that was created out of a need, because drug and alcohol testing is a big deal anywhere in the world. But the only places that it's got any type of structure or guidance or standard is in Canada and the U.S. So I was speaking at an international conference a couple of years ago in Salzburg. They wanted to know about legalization of cannabis and what our lessons had been learned at that point, which were not a lot and we're still learning. But I became, as part of that conference, the medical review component was part of it, and it became readily apparent that there were no standards internationally, and there was this huge gap. So a group of us from across the world got together, and we just last month finalized a standard, and we have recently applied for ISO certification in the European format, and once that's done, we'll move on to other areas as well. So I'm really, really excited about that, because it's bringing some clarity to an area where it's been desperately needed for a very long time. And then as part of that as well, it extends to concerns and challenges arise when there is no guidance. And unlike the U.S. and Canada, we don't have any guidance to address substance use in the workplace. So we're guided by case law and best practices. And I'm connected to some people who have a lot of knowledge and expertise in many different areas. And those are the resources I use to inform the work that I do. So when I have questions I don't know the answers to, I'm very fortunate to have a large group of people that I can draw on depending on what the area of expertise is that I need accessed. So that's probably too much information, but that's a little bit about
Very
me.
Impressive. Very impressive. So that puts you in a great position then to answer my next question. And that is, if a workplace calls you in and says, look, let's start at a very high level. What's sort of the state of substance abuse in workplaces in general, whether it's here in Atlantic Canada or across Canada? How big an issue is it? What all would you like workplaces to know relative to that topic?
Well, no workplace is immune. Addiction, substance use does not discriminate. Addiction doesn't discriminate. It doesn't matter who you are. And so if you look at the stats, the best evidence that we have, it's self-reported. So it's artificially low. And I think you and I were speaking about this last week, Pearlie, where, from the information, the most recent information I've seen, it's between 10 and 15%. I think that's artificially low. It's at least 20, if not more. And in some sectors, it's much higher. And then there are a lot of contributing factors within healthcare. If you're working in isolation, you're working night shifts, you're working alone, and you have access, OR physicians and nurses and pharmacists, anyone who's involved with the distribution of narcotics and controlled substances, use is higher because of access. Certain sectors, many of the trades, and this is not to pick on the trades, but it becomes almost like an endemic culture. And that was one of the things I first noticed when I was working as a narcotic inspector, that there were certain populations in certain sectors and certain areas where substance use started for whatever reason, and then it became a multi-generational cultural situation. And that varies, it ebbs and flows, but a lot of it has to do with access and acceptability. Peer pressure is a huge part of substance use as well. So if you think that you don't have a substance use problem in your workplace, you are sadly mistaken. And, that's called denial. And you can do the ostrich scenario and stick your head in the sand, but that's not going to make it go away. So my recommendation is that you be as open and as transparent as you can with all your employees. Make them aware of the concerns and why, and put parameters in place to address it when you have an issue.
Now, when you look at substance abuse, of course, we go back to the sort of the old type that was probably more predominant, and that's alcohol.
Yes.
What can you tell us about alcohol as one of the many types of substance abuse issues?
It is still the greatest substance of concern. The use, the prevalence, accessibility. And I mean, we have culturally been normalized to alcohol use for a very long time. I grew up on the South Shore of Nova Scotia. Within the fishing industry, you didn't get off the boat and set your boots on the wharf, and your next stop was the liquor store. You didn't go home. You didn't go anywhere else. That was the first stop. And often that continued until you got back on the boat again. And with some scenarios, it continued when you were fishing, but that's another issue. That's why there's still problems within the marine industry. But alcohol is the biggest concern. It's easy to hide. It's accepted. It's not viewed. I talked about stigma a little bit earlier. It's not viewed with the same stigma that drug use is. It's very different. And, I was just looking at a recent document. The Canadian Centre for Substance Use published a document that I'm happy to share with you the resource of, and it's the Canadian Substance Use Cost and Harm Study, and it was just published last year. And it identifies that alcohol is still by far head and shoulders above any other substance with regard to costs from every angle you look at it. It's crazy, followed by tobacco, and then subsequent to that are other substances. So, Alcohol is a carcinogen. It's a toxin. It's so destructive to our bodies in so many ways, and it impacts us mentally, of course, as well. The one difference that makes alcohol easier to deal with in some contexts is that use is predictable, not only because we've got such a familiarization in history, but the way alcohol is consumed. If you're healthy and you're drinking alcohol infrequently, periodically, you'll metabolize a drink an hour. And what's a drink? It's a beer, it's 5.5 ounces of wine, or it's 1.5 ounces of hard liquor. So you can do the math on how much you're consuming and how quickly it will leave your system. No other drug is like that I know of. It's called first order kinetics, and it's easy to predict. So, you can drink to a certain point the night before work, and then you can go to work the next day, and you can predict whether or not you're going to be safe. Now, the other part of that is the hangover effect or the after effects of alcohol can be equally as damaging, but you're not going to have a breath alcohol level that will indicate that you're impaired. So it's much more difficult to measure the hangover effect. But with substances.
Talk more about this hangover effect.
Oh, well, I don't know a lot about it. I don't have a lot of science to support it, but if you're drinking a lot, and it depends on so many variables, your pattern of consumption, your physicality and what kind of shape you're in physically, your metabolism, your health, all of those things. But once you stop drinking alcohol, you rid it from your system within that 8-hour period after consumption. Mm-hmm. But you still have like the metabolic effects. You have some of the cognitive fogging. You have all of those things that can still make you unsafe, even though your alcohol level may not be detectable from an impairment perspective.
Yeah, and that's what I was wondering. A lot of people would say, well, look, I was out drinking last night. I drank till midnight or 1 a.m, but, then I went home, went to bed. So, hey, I'm really good to go the next day. But the reality is they're not.
You may not be. You may be, but you may not be. And there's ways to mitigate a lot of that. You can hydrate really well, take your B and C vitamins, and make sure that you get good sleep, and that, all of those things, good hygiene that makes sense in any respect, sleep hygiene and just normally looking after yourself. But you're still going to generally have some sort of hangover effect unless you're consuming alcohol on a regular basis. And then your tolerance to a lot of that develops over time as well. The problem, Pearlie, is that we're all individuals and everyone's different. And so it's not predictable, right? The cause and effect. One, you may have a correlation, but correlation does not mean causation, if you know what I mean.
Yep.
Yeah. So
now you used another word a moment ago, and maybe you could talk a little more about that as well, and that's tolerance. Some people will say, well, look, hey, I drink on a reasonably regular basis, so, I have a high tolerance build up. So, yeah, I can drink a fair bit and show up to work the next day, and I'm good to go. I'm quick, and I've got my agility and all the things I need to do my job safely. What's your thoughts on that?
Well, again, I'm not an expert in alcohol consumption, but what I do know is, that's purported quite regularly, and some people will even go so far as to say, I'd rather have someone who's a functional alcoholic than have them working and not drinking because they're more dangerous. And that could very well be. I'm not in a position to say one way or the other. But what I can say is when you have an alcohol level that is detectable for our level of impairment, and generally it's down at 0.05 now, then you're not safe. You're not safe to drive. You're not safe to be working in safety-sensitive positions. End of story. It doesn't matter how you feel, because a breath measurement is not the only thing, but that's the best we have, and that's the standard that's legally acceptable as well. Now, I can tell you that evidence will show that even at 0.02%, we're cognitively compromised and not safe to work in safety-sensitive positions. Under the U.S. DOT, U.S. Department of Transportation, for any federally regulated transportation industry like trucking and rail and airline and many of those sectors, their level is 0.02.
Okay.
If you're 0.02 to 0.04, you're not in violation of a policy, but you're suspended for safety reasons for 24 hours.
Now, the study you just mentioned, to go back to it for one moment, does it give any costs associated with what does it really cost in the Canadian economy or company costs, et cetera?
Well, it's interesting. It's funny that you asked that. So I was looking at this reference that I did cite earlier, and they talk about direct and indirect costs, and specifically what they mention, and I can, as I said, share this reference with you. Lost productivity costs they refer to as premature death, long-term disability, and short-term disability, under which they categorize absenteeism and impaired job performance or presenteeism. So they say the loss of productivity to substance use in 2020 amounted to $22.4 billion.
Wow.
Yep. That's $589 per person, and the attributable deaths were over 74,000. I know, it's crazy.
Yeah.
And so, but I thought that was interesting. So I thought there's more costs. So then there's another category that they call other, and they say that the social assistance, this part of the study reports that the social assistance for substance use attributable disability, so it's going a little deeper, and workplace costs, which is what we want to know about, not already covered in the lost productivity, so the part I just referenced to you. So they're under this category, they're looking at employee assistance programs, drug testing programs, and administrative costs associated with workers' comp. Those other direct costs, $3.3 billion in 2020. $3.3 billion. And alcohol use accounted for almost 50% of that. So alcohol's still way up there. Sorry, go ahead.
Now, when they talk about fatalities or deaths attributed to the substance abuse, do they break it down at all, the difference between employment and non-employment?
No.
They don't.
No.
That'd be a curious one as to, I guess we're all very familiar with drinking and driving and people that die from different factors related to drinking in their personal life and medical conditions. But
yes,
you wonder, do you know of any research that's been done relative to trying to identify the number of people that were either injured or died, and maybe you could do some research on this if you don't know, and we could talk about it on our next podcast. But has there been any research done relative to, someone that's tried to determine how many people are dying on the job as a result
of workplace of substance use,
dying as a workplace as a result of substance abuse or being injured?
Yeah, and I don't know the answer to that, but I know where I can go to find out if there are any recent stats. The one thing that was also under this other direct cost sector section of the report, it says that over $1.3 billion, so it partially answers your question, was spent on damage to motor vehicles because of collisions related to substance use. So we've got that part of it, but it doesn't differentiate between whether or not they were working, and it's specifically motor vehicle collisions. So that wouldn't include things that work like forklifts and any, operating equipment that might have been, resulted in a fatality.
Now, I asked one of the vice presidents of WorkSafe one time a number of years ago as to whether or not when a worker died on the job, if they automatically did any testing relative to that. And I was really surprised. His answer was no.
And I don't know why that is.
I would have, now I don't know if that's standard across Canada, but I would have thought that it would almost be something that would be standard in the testing that would be done after the fact. That, if nothing else, to help from a preventative point of view.
I know.
We've talked a lot about alcohol, and we'll ask you to do a little bit of research on this last topic before our next podcast. You talked earlier about the medical model, and we talked this morning about a number of drugs that are out there. There are all kinds of different illegal drugs, so what people refer to as illegal drugs. There's marijuana, of course. There are prescription drugs. Now, you talked to me this morning about a medical model that's used that sort of puts them all together and doesn't differentiate. Talk to our listeners about that. I found that very interesting.
Well, I find that we are very quick to, we generally as a population, Canadian and even more so in the States, to make a differentiation between legal and illegal drugs. And I've always said, your body doesn't care. Why is it a big deal? Right? A substance that makes you unsafe is a substance that makes you unsafe. And so when you use the term legal versus illegal, you're adding another layer of judgment and stigma. And it's almost like you're approaching it from a policing perspective, right? So, and that's not the employer's role. And too often I find in the work that I do, employers feel consciously or unconsciously have the attitude that they're in a policing role. And so they're focusing on basically identifying bad people and terminating them and getting them out of the workplace versus recognizing that it is a health disorder, just like diabetes, or not just like, but it's not unlike diabetes being a health disorder or cardiovascular disease or any of those disorders. They're medical situations that require treatment. Excuse me. And that's why I reference the medical model, because it's very different. And it's a approach from the perspective of helping a person get healthy and safe and get them back to work.
Okay. Now, when you look at the different types of drugs that are used, I know I read a few years ago about offshore work on the oil rigs in Newfoundland, and there had been a high usage of marijuana. But of course, when the testing was being done, marijuana shows up quite quickly in your body and stays in your body. So a lot of the workers had switched from marijuana to cocaine and other harder drugs. And I thought, whoa, horrible. What's your take on what's happening out there in the industry do you have any take as far as what drugs are most commonly being used?
There's a whole bunch of layers there. So maybe I'll start with the common uses. Cannabis is still the most prevalent substance used generally across the board. Doesn't matter, workplaces or outside of workplaces. And in my experience with employees in workplaces, cocaine is number 2. Cocaine is readily available. It's relatively inexpensive and it's normalized. It's frightening. It's even very commonly used with kids in high school and maybe even lower than high school. It's really frightening. So, yeah. Your comment about cannabis is it relates to the testing, and there have been some progressions in testing over the years. And this again defaults back to the U.S. Department of Transportation, because we don't have any legislation or regulations in Canada. Most companies who started doing testing in Canada defaulted to the U.S. model, and that was urine testing only. And the problem with THC, and I say this probably at least once a day, is cannabis is unlike any other substance I know. And I've been a pharmacist for quite a while, but it's unlike any other drug. It's absorbed in your system, and let's use smoking as an example. So you smoke it, you get high for, I don't know, a couple hours, so maybe a few minutes to a couple hours, and then you come down. That high comes down. So what happens is the cannabis is absorbed into your system. It's fat soluble. So a lipid soluble substance will very quickly get into the fat cells in our body. And that's in our brain and everywhere else in our body. So depending on our body composition and our metabolism, it's going to stay around for quite a while. And that's why you hear people say, well, you can test positive for up to 30 days afterwards. Yeah, you can if you're doing urine testing, if you're using high concentrations and you're using it frequently. If you're an infrequent user, it's unlikely. But that's when I get the comment, you're forcing me to use cocaine. Well, no, I'm not forcing you to do anything. The logic of that comment. But the other part of this is, I have a problem with urine testing from a whole bunch of perspectives, but in the workplace, the only time in my world that urine testing is appropriate is if it's return to work and ongoing follow-up treatment. If you're back at work and you have to be tested every whatever the frequency is, then that urine testing is appropriate because you're looking for metabolites. And I say otherwise, if you're testing urine, all you're going to get are results from expensive pee that you're paying for to have analyzed. And I'm sorry if that seems a bit rude, but it helps people remember that. And a metabolite, they're inactive metabolites, which means they have no activity in the body. So all that proves is it's gone through your system. If you're doing reasonable cause testing or post-incident testing, the only thing that will withstand, or the best test results that will withstand any legal rigor, are oral fluid testing because you're getting active drugs. So in your saliva, if you've got an active drug that's proven to be there from a lab analyzed, not a quick test, but a lab analyzed assessment, then you can say with relatively high certainty that person is unsafe. They're not impaired. I don't use the word impaired because we don't have any measure. And again, pharmacist for a while, I don't know any drug at a particular level that you can say someone is impaired, with the exception of blood for cannabis and cocaine, because when cannabis was legalized, the Federal Department of Justice identified blood drug levels for the first time, and they included cannabis and cocaine. And there were some other substances, but they're generally not a concern in the workplace. So those are the two that police will test at roadside for. And so those are the only measures that you can say with, just like the breathalyzer, if you've got this level and it's 2, 2.5, and 5 nanograms of cannabis, depending on some other factors involved, then you are legally impaired, and there's a charge for impaired driving under the Federal Criminal Code. So that's a lot of information about testing, but testing is so misunderstood, and so many people just get all tangled up in it, and they don't really understand the nuances of what I've just said. And it's critical because without that knowledge and without that approach, employers are making decisions on testing that are ill-advised, and it's not going to serve them well if there's ever any challenge.
Okay, so we'll get into more testing, by the way, on our second podcast. Now, to go back to a couple of things you've said, because, every time you say one thing, it sort of pops another question. Are there any drugs besides marijuana and cocaine? Are there any other drugs out there that's being used fairly commonly among addicts or among people that are in the workplace?
So I'm going to be the language nerd here, and I'm going to say I don't use the term addicts because it's discriminatory. I would say this to anybody, Pearlie. So I don't mean to sound like I'm picking on you, but it's part of the education piece. So people with substance use disorders or people who have an addiction to a substance. No. It's just like, and I'm so picky. I'm a nerd. I'm so picky that I try not to use the term diabetic. It's people with diabetes. Right? So you see, It's the labeling stuff. So anyway, opiates are a big problem too. Again, especially prescription opiates. So when I was a narcotic inspector, oh my dear, they were a huge problem, but no one really, wasn't on anybody's radar, and no one was paying attention to it. My clients, I had them employers testing for opiates, synthetic and semi-synthetic opiates, since I started working in this position, because I knew they were a problem, but nobody was testing for them, again, because the USDOT did not have them on their panel. And the USDOT is government. It takes forever, as we all know, for governments to change regulations and any standard. So finally, I think it was about 4 or 5 years ago now, their panel did change, and they now include semi-synthetic opiates and synthetic opiates. So opiates for sure, and amphetamines as well, less so. So I would say in that order of prevalence, there would be cannabis, cocaine, opiates, and amphetamines. And the other one, I almost forgot, are benzodiazepines. So things like Valium, Ativan, Cirex, Xanax, anything, diazepam, lorazepam, clonazepam. I say, and any other damn Pam there is, if the chemical names end in a Pam, then it's a pretty good chance it's a benzodiazepine. They're highly abused, misused, overprescribed like crazy. And if someone has an alcohol use disorder, benzodiazepines will often help with the withdrawal from alcohol. But that doesn't make the person safe. It's the lesser of two evils. Maybe, maybe not.
Now, you mentioned all these different drugs.
Mm-hmm.
How concerned should workplaces be with the usage of all of those different kinds of medications when it comes to people in their workplace?
Well, so there's one thing I forgot to...
And why I ask that question is this. Over the last decade, as I do workshops around the province, I continually get people to say to me, well, I really don't have to worry. Yes, I take some prescription medications, but they're all right because they're prescribed by a doctor. Right. So, yeah, I'm taking such and such a medication, and yeah, I know it's strong, but I'm still good to drive a forklift, for example, aren't I? And I'll often ask a simple question, well, what does it say, for example, on the label, or what kind of advice comes with it? What do you say relative to those issues?
Well, just because something's prescription doesn't mean it's safe. And no drug acts where we solely want it to act, right? Drugs aren't specific. Unless they're one of the, well, I'm not going to get into new technology, but generally speaking, a drug acts all over our body. And that's why we have side effects or adverse effects. It hopefully works where we want it to, but that also impacts other parts of our body that have some untoward side effects. So that negates it's prescription, so it's safe part. I often get the same thing around, it's natural, so it's safe. I say, yeah, well, so is arsenic. So anyway, so this is a really important educational piece for employers. It's important they address it in their policy. That you identify that if someone's taking any prescription medication, the onus is, and they're working in safety sensitive positions, the onus is on them to ask the questions of their pharmacist, of their physician, of their nurse practitioner, is this going to make me unsafe for work? And you'd be amazed the number of times I get involved with investigations and the physician doesn't even know the type of work that their patient does. So that's step number one. And so then you make it easy for the employee to come forward in an appropriate process that maintains and respects confidentiality. And a lot of employers will say, I need to know the drugs. No, you don't. Where's your medical degree? And that's going to give you information that you don't need to have access to, and you're invading a person's privacy, and you could be in a liability situation. So the onus is on the person to provide information whether or not they're taking something that can make them unsafe, and then the employer has the duty to accommodate. That's plain and simple how it should be. But the first step is for the employer to educate the employee to ask the questions of the health professionals that know, and then make the decision accordingly how they're going to progress, what their next step will be.
So you talked a moment ago about safety-sensitive positions.
Mm-hmm.
Explain to our audience exactly what you mean by that.
The
because
definition.
I hear that term thrown around a lot.
Okay, so I'm going to grab another reference because I want to make sure I reference this properly. Safety-sensitive position. So this comes from a standard reference. It's a position or class of positions identified by the employer, articulated as per another section, that normally work with a hazardous work site. And there's also risk sensitive. And so that really applies to people who are in managerial positions. I'm sure you know this, who oversee safety sensitive positions. So it's generally if you're working in an environment that's highly risk sensitive, safety sensitive, risk sensitive. So it can be in the environment and it can be the nature of the work that you do. So, the case law has not been very kind to employers who just generally say, well, my whole workplace is safety sensitive. Well, that may very well be, but to be legally defensible, you have to have gone through a methodical process to determine what are the different works environments, what's the type of work that's being done, and grid it. Is it green? Is it orange? Or is it red? Is it, somewhat safety sensitive depending on certain circumstances, or is it always safety sensitive? So that's generally how an employer best practices to determine whether or not their environment and the work that their people are doing is safety sensitive. Many of my clients choose to apply their drug and alcohol policies across the board because I've always said, why would you discriminate and only give your employees who are in safety sensitive positions the benefit of having assistance if they have a substance use disorder? You still have an obligation to support them regardless. So, and it's often accepted more readily in general by a workplace if it's an application across the board. So I know my position on that's different than some, but that's been my experience.
Now, to go back to a topic a few minutes ago, and that's marijuana. Was legalized here in Canada a few years ago. What lessons, what came out of that legalization? I know at the time before it was legalized, there was almost a panic that this is coming down the tube, and workplaces panicked, and we don't know what we're going to do, we don't know how we're going to handle it, and so on. And then after it happened, it was quiet. It was just, didn't seem to be any articles, any stories about, this having any kind of effect. What have you heard relative to lessons that we've learned, or just information that, is it an issue?
Oh, it's a huge issue. And I think just because we haven't seen a lot of it in the media or you haven't heard about it being reported doesn't mean it's not happening, because I see it every day. What unfortunately has happened in many circumstances is that it's become so normalized, and employers don't always know what to do. And so some employers have even decided to remove cannabis from their testing panel. And my first question is, why? And the answer I usually get is, well, because it's legal. I say, yeah, well, so is alcohol. So, like, how do you defend that, right? And so then you get into it. You know what I'm going to say? It circles back to the problem around testing. And actually, for a while, before legalization, employees would use the perspective of using cannabis for medical purposes. Well, I have a process that I use, that I go through. It's a very methodical, vetted process that determines whether or not someone is using it appropriately, and is it safe for them to use it if they're working in safety sensitive positions. And I have not had one case where anyone who's gone through that process has ever been approved to use cannabis in a safety sensitive position. Doesn't matter. And, and the other part of that is that there's a lot of evidence to prove that it's ineffective for most medical treatments, with the exception of 2 or 3. And it's only then as a 3rd or 4th line treatment after many other things have been tried, many other recognized treatments, and in conjunction with other treatments. So that's somewhat dissipated because I think the access to cannabis is so readily available. But it's a huge problem. I've had clients that have had, they've said to me, I know I've got people smoking outside the gates. And, I can't do anything because it's legal. And I said, well, yes, you can. And, if they're smoking cannabis and you do an oral fluid test and it's positive, they are not safe to be working, period. So, and again, I'm going to go back to the first step, is having a program or a policy in place, but then educating your people so they understand this. They're not being discriminated against. But I spend a lot of time working with the employees of my clients to help them understand the difference about cannabis, because it stays in your system so much longer. And if you're using a lot every day, it can take a long time to clear out of your system. But it doesn't matter what's in your pee, it's what's in your saliva. And if your saliva is positive, you have active circulating drug and you're not safe. Period.
Now, to go back to a comment you made quite early, actually, in our podcast, and that's about specific jobs and industries that might be more susceptible to substance abuse. From the research that you've read, are there any jobs or industries that are more susceptible, that generally it's considered that there's maybe a higher level because of the nature of the job. Like earlier, I did a podcast with Rory Siliker from the NBCSA, and he talked about, for example, the rate of suicide in the construction industry from the point of view of a number of factors that put a lot of stress on the worker, and a lot of them deal with it through the usage. Anything that stands out? You mentioned healthcare a moment ago, because
Healthcare.
it can be accessible.
Yep.
Any
Healthcare
others?
and the stress within healthcare as well, especially today more than ever before. High stress positions in any environment. And I've always said too, Pearlie, addiction doesn't discriminate. No one is immune from addiction. They really aren't. And, stockbrokers, physicians, lawyers, anyone who's in a position, often if they work in isolation or with minimal supervision, that's one. And if their job is stressful in any one of a number of ways. And the trades, and I said this before, I don't mean to sound like I'm picking on the trades. It's not because they're blue collar versus white collar, because there's just as much, if not more, substance use within white collar areas of practice or jobs. But there are certain sectors within construction that it's more prevalent. And I don't want to get into particulars, but it's normalized. And you just walk by any construction site and you can usually smell pot before work, at lunch, at breaks in the morning, in the afternoon. It's very prevalent. And again, employers turn a blind eye because they don't know what to do, or they don't think they have an option.
Well, look, as much as we could talk about this topic for a long, long time, I think I'll cut it off there today, because really your last comment is a great segue into our next podcast that we're going to do, and that is a lot of employers, as you just said, don't know what to do. Well, for our next podcast, for folks that have been listening today, that's exactly what the question that Nadine is going to answer for you is what can you do? What options are available for you to help those employees, to identify and help them, and what the laws say that you can do, you can't do? It's a complicated issue. So again, as I mentioned at the introduction of today's podcast, if you've listened to today's podcast and you have any other questions you'd like to ask Nadine, send them to us. There's so many different topics that we could have talked about. But if you have any questions, send them off to us at podcast@ssnb.ca. That's podcast@ssnb.ca. As well, in our next podcast, Nadine is going to talk to us about fit for duty and help, that generally advice that she could provide to employers. So if you have any questions relative to that topic, send them off to us as well. And we'll bring them up, and I'll ask them directly to Nadine. And I'll tell you, with her background, she has all kinds of answers that she can provide. So thank you very much, Nadine, for being with us today. Certainly you have a tremendous background. You've been a lot of different places and done a lot of things. And we'll maybe talk some more about those as well on our next podcast.
Sure.
So until our next...
I was just going to say thank you, Pearlie. I didn't mean to interrupt you there, but thank you for the opportunity, because as you can probably tell, I'm a bit of a nerd, and the whole education piece is so important, because you can't do anything differently unless you know differently. And there's so much misinformation around so many of these topics that any way I have to be able to give people some additional factual, scientific information that's not based on self-motivated interest, we'll just leave it at that, is important, so that people can then, or I can give you also resources so that you can then research yourself and find out more about what you may be interested in or need to do more on.
It's such an important topic, and I'm sure pretty much folks listening today, you've either worked with people who have substance abuse issues. I know I have. You've dealt with people on the job that have substance abuse issues. It's hard. I know in my case, during workshops, not uncommon at all to have someone come up to me at break and say, look, can I ask you a sort of a personal kind of question? And the question was, that they work with someone who has a substance abuse issue. They're very concerned about their health and safety, as well as the individual's health and safety. But they're reluctant because they don't want to squeal on their friend. but they're concerned for their safety. And that's very, very common, unfortunately, in our workplaces. So that we'll get into on our next podcast. Again, thank you very much, Nadine.
My pleasure.
And again, for folks listening, send us your questions. We'd love to hear from you. That's podcast@ssnb.ca. Stay safe. We'll see you next week.